sodium, which is Na. It is, the normal range is 135 to 145 milliequivalent per deciliter. So kind of like potassium, it's got the milliequivalent per deciliter. It is a cation in the extracellular fluid. Cation means positively charged, and the potassium, whereas that was inside of the cell. Sorry, there was a noise. So the main job for sodium is it's going to be a conduction of your nerve impulses. The kidneys will regulate sodium with ADH, so an antidiuretic hormone. It will also regulate with aldosterone and a natriuretic peptide. And then one thing to remember is water and sodium absolutely love each other. They are like inseparable. So if sodium were to leave the body, then water is going to follow. If sodium comes in, then water follows. Wherever sodium goes, water goes, vice versa. So now that I've talked about what it kind of is, we're going to talk now about the causes of hyponatremia. So with that, you can kind of think of, I don't know if you can see it because of the glare. That made it worse. Okay. Think of no nat. So like no nat, like I guess nat, the T doesn't really stand for anything. So for the first one, like the sodium excretion is increased with renal issues, when there's vomiting, sweating. So that means your body's getting rid of a lot of sodium when it doesn't need to. You're going to have an overload of fluids, so like a patient that has CHF, congestive heart failure. And then sodium intake is going to be decreased, so kind of like with potassium. If we don't get enough potassium, then we have hypokalemia. Not enough sodium, hyponatremia. And then also an antidiuretic hormone, so that ADH that I talked about over here, is going to be oversecreted. So that's kind of where these can pair together. Because you have so much of the antidiuretic hormone, you're kind of holding it capped. So scratch that actually. So this means you're getting rid of it too much. You want to get rid of it. The antidiuretic is going to hold on to the water. So with that being said, if you're holding on to water, remember sodium and water love each other. So you're holding on to that water, you're going to hold on to that sodium. Pardon me. So signs of hyponatremia, you can think salt loss. I kind of broke it down into salt and loss. I didn't want to squeeze it all here. So S, you're going to have seizures and stupor. And then A, you're going to have abdominal cramps. You're going to have possible attitude changes. So think cognitive as well. Because if they have seizures, they might have some attitude changes. Seizures, you could have some brain swelling. You could have a lot of things. Lethargic. Also, tendon reflexes will be a sign. Like, I'm pretty sure it's like an increase in tendon reflexes. I can't remember. Loss of urine. So we get into the loss part. So loss of urine and appetite. So if they aren't having an appetite, they could possibly be nauseous. They could have anorexia, and also loss of urine, meaning they don't make the urine, which could make sense because of the antidiuretic hormone. It's causing you to hold on to it, so you're not getting rid of it. Shallow respirations, and then spasms of the muscles. So we could bring that paresthesia back into it, and I talked about that with potassium. So I am going to kind of get rid of this, and then we will talk about hypernatremia. So now we get into the causes of hypernatremia. Think of high salt. So we had a thing with like salt loss, and that makes sense because it's hypo. So hyper, we're gonna have high salt. So hypercortisolism, so that comes with like ventilation, like hyperventilating. So having the constant hyperventilating can cause that, as well as increased sodium intake. Anyone with a like GI feeding. So like if they have a feeding tube, if they're getting excess amount without having like proper water to kind of help balance it out, that can cause it. The sodium excretion is going to go down. So that is kind of with your corticosteroids. And then I forgot the H, so hypertonic fluids also. Having aldosterone problems, because aldosterone is secreted with is produced in the adrenal gland, and that is where it will hold on to the sodium and also hold on to the water. So if they have aldosterone problems and say they have too much, then they're going to hold on to way too much. Loss of fluids, so kind of like dehydration, and then the thirst impairment. So signs of hypernatremia, think no fried foods, and then think of the fried part. So fever and flushed skin. You'll have restlessness, so you can have agitation as well. Increased fluid retention. Fluid retention, they have a loss of fluid. They're not having enough fluids because they're dehydrated. So you want to get them increased in fluids. You'll have that retention, and then you have the aldosterone. It all works together. If you have too much of one thing, then it can impair a lot of other things. So you can have edema. So they could also be confused with it. And then also a decrease in urinary output. So that can also be like dry mouth. You could throw that back into dehydration. So if someone's dehydrated, they're not going to have that normal skin that you and I have. They're going to have they're going to be dry. You'd think brittle, kind of, not really brittle, but like they're dry, cracky, and you don't want that. You want them to be able to, you want to get that back down. You want it to be where they are normal. They can have a normal increased or normal urinary output. All right. Thank you for listening.